Hello everyone, in this video we are going to see in detail about diagnosis in endodontics. If you ask me, what's the single most important criteria which differentiate a mediocre dentist from a successful dentist is their ability to diagnose the disease. This can be simplified into this quote. The first step in solving a problem is finding out what the problem is. A patient is coming to us with a problem. So what's our responsibility? We have to diagnose the disease. Then only we will be able to plan a treatment and we will be able to execute the treatment. So I am not going to talk in a textbook manner. I am going to give 4 important criteria or steps by which we can do the diagnosis. The first one is the listening to the history of the illness. Next is to do a proper clinical examination. Then we have to do a vitality testing, and finally we have to do a radiographic examination. By doing these 4 important steps, we will be able to diagnose most of the clinical illness whatever the patient is coming with. So what makes you going to be a successful dentist is to paying attention for these 4 important steps in the history taking, the clinical examination, and doing a vitality testing and a radiographic examination. Let's see one by one. First, let's see what is the importance of a history in diagnosing an endodontic disease. The only difference between a dentist and a patient is the patient doesn't know what's the technical term for the diseases, but who is suffering from the disease, and the dentist knows the technical term for all the diseases but doesn't know what's the problem that the patient is suffering from. So what we are supposed to do is we have to talk with the patient by asking whatever the problems that the patient is undergoing, and we can make a final diagnosis. The first step that we have to understand is most patients cannot differentiate between sensitivity and pain. Whenever a patient says that they are having pain, it could be pain or it could be sensitivity. So it is a common practice that whenever a patient says pain, that we always jump to the diagnosis that there is a pulpal problem and we have to go for a root canal treatment, or maybe the next option is to do an extraction. No, the pulp do not have all the receptors for differentiating between sensitivity and pain. So most patients, whenever they say pain, it could be a sensitivity also. But if someone is saying sensitivity, most often it is not pain and it could be sensitivity. So pain means it is pain or sensitivity. Sensitivity means most often it is just sensitivity. Keep this in some backside of our brain so that whenever we are going through the further steps, it will be easy. So next, whenever a patient complains of pain or sensitivity, whenever they are eating something sweet, so with a sweet food, they are complaining of pain or sensitivity, we can come to a diagnosis that the decay is in enamel or in the close to the dentino-enamel junction, or in the outermost dentin close to the dentino-enamel junction. So whenever a decay is in an initial stage which just enters or touches the dentino-enamel junction, whenever the patient is eating something sweet, they will get sensitivity. So sweet means it is the enamel or dentino-enamel junction. Keep that in our mind. Okay, next is whenever the patient is eating something which is cold like an ice cream and they are having sensitivity, means it is the outer or the middle dentin. So sweet means enamel or dentino-enamel junction, and cold, that is ice cream or something like that which is cold, means it is outer dentin or probably the middle portion of the dentin. And the third thing is whenever the patient is complaining, whenever I drink something hot or eat something hot, I am getting pain, means the caries has progressed deeper and deeper and the decay has spread close to the pulp, that is the inner dentin, or maybe the decay is quite closer to the dentin, the pulp. Okay, so sweet, then cold, then hot. Okay, so that's the step. That's how the patients will give symptoms. And the next is, some patients say that whenever I am eating something, some food, whenever the food goes inside the decay, I get pain. Means one, it is almost touch the dental pulp, or it is very close to the dental pulp. So just before the patient opens their mouth, we could say that whether the decay is it in enamel, or it is an outer dentine, or inner dentine, or just which is close to the pulp, without checking the patient mouth, just by asking some important questions or just listening to what the patient says. Okay, so then this everyone may be aware. Whenever the patient comes to the dental clinic and say that, doctor, whenever I am trying to sleep, I am not able to sleep, and whenever I lie down, the pain increases. Or yesterday night I was not able to sleep at all. Whenever I get up, I feel little better, but when I lie down, I feel so much painful. So this is a typical example of irreversible pulpitis, and probably the tooth may need a root canal treatment. So pain at night or while sleeping is irreversible pulpitis, means the decay has progressed from enamel, dentine and touched the pulp, and the pulp is now irreversibly inflamed, probably needs a root canal treatment. And one important factor that the patient often says, and we might omit, is the swelling, the history of the swelling. So whenever the patient gives a history of multiple swelling, we could say that the pulp is non-vital. So in case of a non-vital tooth, there could be a repeated incidence of swelling, but the time that they would have visited the dental office, they may not have any swelling, but just a history of the swelling in the past gives an important idea about the vitality status of the tooth. So we should always ask the patient, have you ever got a swelling in the past days? Okay, so then repeated swelling with the discharge of the pus says that there is a persistent infection, and there probably, if you are doing a proper examination, there could be a sinus tract. Okay, so whenever there is a history of pus discharge, or maybe there is a pus discharge through the sinus intraorally or extraorally, there is a persistent infection. Just probably we can say that it is probably a tooth from an young patient, or which is having a big pulp chamber and a wide root canals, often leads to swelling and also pus discharge. Okay, so whenever the patient complains of ear pain, so again this is a common symptom that the patient often gives while we are taking the history. Doctor, I am having a ear pain. Ear pain means most probably it is coming from mandibular molars. So patient always relate ear pain to the maxillary teeth, but ear pain is often associated with mandibular molars. More probably maybe from an impacted tooth, or a decay, or a pulpal disease from the third molar, maybe any of the mandibular molars. Okay, next, one more important history point that the patient gives is the tooth is mobile. So whenever we hear the word the tooth is mobile, we often say that the patient is having a periodontal problem. Trust me, whenever the tooth is getting infected, there will be formation of the pus. This pus get accumulated in the space between the tooth and the socket, which is the periodontal space. So in the periodontal ligament space, whenever the pus get accumulated, it push the tooth out of the socket and the tooth will be mobile. So whenever the patient complains of a mobile tooth, or whenever they say that the tooth is elevated, we should ask them, is that is the only tooth which is mobile, or almost all the teeth are mobile? If multiple teeth are mobile, then it could be a periodontal problem. If there is one specific tooth which is mobile, then most probably it is a illness, it is a problem with of endodontic origin. So non-vital tooth can become mobile and it may be elevated, and the patient, whenever they are chewing, that tooth will be the only tooth which comes in contact prematurely while doing occlusion, and this is a important aid in making a good diagnosis. And next is, patient says that they are having pain in the upper tooth, maybe maxillary, second premolar or first molar or something. We do a radiographic examination, we can do a clinical examination, we find there are no problems, but one of the important consideration is the maxillary sinusitis. Maxillary sinusitis patients often they may not have any complaints of a sinus infection, probably they will have only the complaint of a painful tooth, and there may be no decay or there may be no other signs or symptoms, but we should always suspect a maxillary sinusitis whenever the complaint is from a maxillary second premolar or a first molar, and the tooth is free of decay or old restorations, or the tooth is non-mobile and the patient is having pain. Always suspect maxillary sinusitis. Ask history about whether the recent occurrence of a sinus infection or something like that, and we will be able to make a diagnosis. So never omit maxillary sinusitis. So that's little about the history that we have to ask the patient or listen to the patient, so that we will be able to make a little steps closer to making a final diagnosis. After asking this history, then we have to go for the clinical examination. So the clinical examination, we have to first inspect, then we have to examine, then we have to palpate, then we have to percuss, and we will go all these steps one by one. Okay, first thing that we have to examine is, which we always do, is whether we will look for a decay or the presence of a old restorations. Whenever we see that the restoration is a small one, but it could be a deeper one. Okay, so whenever there is a restoration, we should never underestimate it. Or there may be a restoration without a proper pulp protection, so that could cause a leakage, or maybe because of the repeated thermal insults there could be a problem, there could be a pulpal infection. Okay, so next thing that we have to examine is whether there is a food impaction. So whenever there is a food impaction, we have to think about two things. One, we have to consider about whether there is a class 2 decay. Whenever there is a class 2 decay, there could be a food impaction, or it could be a gingival recession, and it could be because of a periodontal problems or a gingival problem. So we have to differentiate between a, whenever there is a food impaction, whether it is periodontal or it could be a conservative or a endodontic origin. So we have to always look for the food impactions. So whenever there is a food impaction, we can indirectly say that it could be most often a class 2 dental caries. Okay, so then the next step is to use a air water, the 3-way syringe, to blast an air. So whenever we are blasting air or air and water, we can make some ideas whether the tooth is vital or non-vital. With a blast of air and the patient is getting sensitivity, we can consider that the tooth is vital. So probably we can look for some conservative procedures like maintaining the tooth vitality even though it is a deep decay. So one important situation where this is very, very helpful is there may be a young patients who may be having a large decay, and maybe everything is brownish or blackish in color, and there may not be a visible swelling, or there may be no history of pain, but on looking at the first appearance, we may think that the tooth is quite grossly decayed or destructed, and we may have to go for a root canal treatment. Try this out. Do a air blast or with a air and water blast, and if the patient is having sensitivity, trust me, the tooth is vital. In many young patients who come in my practice, who have looks like a grossly destructed appearance, but the teeth are all vital, because in young patients the pulpal immunity or the resistance or the reparative dentin formation will be at a very higher rate. So the tooth, the chances for it to become non-vital are quite less. So always look this, and this is an inexpensive and non-time consuming test. So we should always practice this. Okay, so then we should always look for whether it is sensitivity or pain. Okay, so how to check for sensitivity or pain? Again, we can use a 3-way syringe, or we can use a CPITN probe, and we can just rub it over the decay or over the abraded areas or towards the fractured area, and we can differentiate whether it is sensitivity or pain. One important step that we should always do is probing inside the cavity with a blunt probe, like a CPITN probe, the ball ended probe. We should use that probe in our practice. We should never probe the deeper part of the cavity with a sharp probe. Always use a CPITN probe to probe inside the cavity. So that gives a lot of idea whether the caries is active or not active, how deeper the cavity is, and whether there is food impaction or no, and whether the floor of the pulp, the cavity, the decay is soft or it is firm or hard. So all this can be taken into consideration, or whether there is sensitivity or pain when we are probing, or even we can see that there may be a direct pulp exposure, there may be a bleeding when we are probing, there may be pain when we are probing. All this gives a conclusive ideas about what the problem is. Next important point that we have to consider is the presence or absence of swelling. So whenever there is a swelling, the swelling can occur buccal or the facial, and it can occur the lingual or the palatal, or it may be gingival or maybe close to the periapical region, wherever it is. But one important criteria for diagnosis are often, which is often confusing, is the palatal swellings. So like we can look at this picture. You can see here there is a palatal swelling in the hard palate, in the palatal aspect of central incisor, lateral incisor and maxillary canine. So which tooth could be the culprit? So whenever there is a palatal swelling in a maxillary region in this location, the most common tooth which is responsible for it is the maxillary lateral incisor. The maxillary lateral incisor often gives, whenever it is infected, the lesion, the swelling may occur in the palatal surface. Next, we can see if your patient is experiencing a swelling close to the palatal aspect of the premolars. Whenever this happens, the most common culprit is a maxillary canine. So whenever it occurs even close to the premolar areas, the culprit could be the maxillary canine. So two teeth which often gives a palatal swelling are maxillary lateral incisor and canine. Maxillary central incisor usually always cause the swelling in the labial aspect, not the palatal. From the maxillary first premolar, from the palatal root also there could be a palatal swelling, but before the occurrence of the palatal swelling, more often there will be a labial or the buccal swelling which happens frequently. So next is, if there is a swelling which is present close to the middle of the palate, where the hard palate and the soft palate are joining together, most probably it is from a maxillary first molar. The maxillary first molar, the palatal root is quite far from the buccal surface, and whenever the tooth is non-vital and the pulp chamber size is quite bigger, and in those situations we can expect a swelling close to the middle. So the probable tooth which is in question is the maxillary first molar. And one important instrument that we always neglect is the periodontal probe. So periodontal probe should be there whenever we are doing a clinical examination, even for an endodontic disease. So it can differentiate whether we have to examine throughout the circumference of the tooth for periodontal pockets, and if you are suspecting at one location there is a deep pocket, usually it is of an endodontic origin. So endodontic origin, there will be a localized pocket and which will be quite deep, and we can suspect that it could be a vertical root fracture. Whenever there is a vertical root fracture, there will be a deep periodontal pocket. And second one is, whenever in case of a maxillary lateral incisor, whenever there is a palatogingival groove, in that situation there will be a deep periodontal pocket. So two situations, vertical root fracture maybe in any of the tooth, and palatogingival groove, there will be an endodontic pocket which is quite deep, and we must always use a periodontal probe in order to find out this. Again, one technique which I love to do, even there is, let's keep that, we have got no idea. Even there is no radiographic change, there is no tooth discoloration, there is no pain, there are no symptoms or the signs or any evidence of a disease. Just try this. With a gloved hand, try to palpate in the periapical region in the buccal aspect of the tooth from central incisor to the third molar. The tooth in question, whenever we are palpating over there, there may be a tenderness. The patient will give a complaint of pain. Maybe in many circumstances, the patient will give a complaint of the pain below the nose. The probable reason could be a lateral incisor canine, or sometimes it could be a maxillary central incisor. So similarly, if you are palpating one tooth by the other, next time when you see a patient where you are confused to make a diagnosis, try this technique and definitely you will be able to come to a pinpoint diagnosis with the tooth. Although it may look like a normal tooth, the patient will have pain whenever we are palpating close to the periapical region with a fingertip. So keep that in our practice. Next is, this is one we always do. So first we tell the patient to open the mouth and we percuss and we say that this tooth is problem. So sometimes the tooth can be quite very painful. So whenever we should always tap with a fingertip, and if you find that the tooth is non-painful, then you go for tapping with the mouth mirror handle. So whenever you are tapping with a fingertip and if you find that the patient gives a complaint that is painful, then there is no need to tap with a mouth mirror handle and make the patient to suffer with more pain. Okay, so next is the vertical percussion with a compared to that of a horizontal percussion. So whenever you are percussing vertically and if the patient is having some pain on vertical percussion, it could be of endodontic origin. And whenever you are percussing from a labial aspect and a labial or a buccal aspect and the patient is having pain, then it could be more probably of a periodontal origin. So vertical, endodontic, horizontal, and it could be a periodontal origin. So then we have to always pay attention to the discolored tooth. So discolored tooth may not be very obvious in many circumstances. It may be a subtle change in the color. So we have to pay attention. So we should always have a keen eye observing just the change of the color. So whenever there is a color change, then we should always pay attention for the probable cause. Maybe we can go for a radiograph or maybe we can go for a vitality testing. So always there may be a small invisible crack line or there may be a mild discoloration. It could give a big idea or an indication about whether the tooth is having a problem or not. So always pay attention for this change in the discoloration. Again, so as I mentioned in the history, we have to examine for the mobility. So whenever we are examining for mobility, what we are supposed to check is whether the tooth is mobile, whether it is grade 1 or grade 2, whatever it is. But what is more important is whether there is a single tooth which is mobile or there are multiple teeth which are mobile. Whenever there are multiple teeth which are mobile, it could be periodontal. Whenever there is a single tooth and whether the mobility has started maybe 1 week back or 2 days back, then 99% it is of endodontic origin and the tooth is non-vital and it is having an abscess. So whenever there is a periapical abscess, the tooth will be mobile. Just trust me, just prepare the access, give a dressing, within 2 or 3 days, the tooth will settle and the mobility will disappear. Okay, so whenever you find that the tooth is mobile, do not jump to a diagnosis of a periodontal problem and the tooth have to be extracted. No, the tooth can be saved. So that's again a very, very important aspect in the clinical examination. Then we have to look for the cracks. So whenever there is a cuspal crack, which is quite common in root canal treated teeth, it is there may not be a full coverage restoration which was placed. In those situations, we can go for a radiograph and we can examine it. So, but if it is a non-root canal treated tooth or if there is a large restoration, in those situations also we have to pay attention whether the crack is what's the level and whether the fracture segment is mobile or not. We have to pay attention for it. Next important clinical examination comes a tooth which is not a root canal treated one, but there is a full coverage restoration and the patient is giving a complaint of pain. So we cannot see whether there is a decay, we cannot see whether there are some underneath some restorations, and then on top of that there is a full coverage restorations. We will have no idea whenever there is a crown tooth. So the only important diagnostic way that we will be able to make a clear-cut diagnosis is take a short probe and at the cervical margin 360 degree just circle and run around it. If there is a decay in a crown tooth, 99% of the time it will be there close to the cervical margin. So if you are with a sharp instrument, if you are running the instrument in the cervical margin at the crown margin 360 degree or to the maximum ability that we could, the probe at least in one point, if there is a decay, it will get bounded. So once if the probe get binded to the decay, then we can go for the further examination or further diagnostic procedures. But keep this in mind, when in a crown tooth, instead of just keep on percussing and tapping over that, so you can do one thing. One, take a probe and in the circumferentially close to the cervical margin, run around with the probe. And next what we can do is, you always try to do it with the palpation in the apical region. So these two will give a idea even in case of a tooth which is crown tooth. So some locations that we may forget to examine while doing clinical examinations. One, the lingual pit of the maxillary lateral incisor. We always look labially and we find, okay, the tooth is looking fine, there are no problems with it. And even if you are looking at a radiograph, the lingual pit, if there is a decay, we cannot appreciate it. So clinically, we have to always look for this location, that is the lingual pit of a maxillary lateral incisor, which we often neglect it or avoid it or we forget it. And the next important is the buccal surface of the maxillary and mandibular third molars. The third molars in the cheeks will cover there, and we often neglect or we often don't look at this location. So always keep it in mind, maxillary and mandibular third molars, the buccal surface. We always look at the occlusal, we always avoid the buccal. So the buccal caries, buccal pit caries of the maxillary and mandibular third molars are very, very common. And what the important point that we have to understand is, it is an area where there are more chances for the dental caries, and we should examine it. Tell the patient to close the mouth and relax the cheek, and then we have to retract the cheek, and then you have to examine it. So that's again one area that is very, very important. Next, some related examinations are the TMJ pain can be related to a tooth pain. So this pain, so how to differentiate is, whenever a patient is giving a complaint of the tooth pain, but probably it could be originating from the temporomandibular joint, the probability of the patient having multiple missing teeth are more, and whenever we are examining the tooth may not have any decay, but the patient will give a complaint whenever they are biting, they are getting pain. So there may be no decay, there may be no signs and symptoms, but whenever they bite hard, there could be a pain that could be originating from the TMJ, but they will correlate it with the tooth pain, and they say that whenever I bite, there is a pain in the tooth. So TMJ pains are also common. Next, one examination that we always omit is the lymph node examinations. So the lymph node examinations gives an idea how long the infection is there persistent. Whenever there is a palpable lymph node, or especially if it is painful, it is acute in origin, and if there is a palpable lymph node and which is non-painful, then it might give an idea that there is a problem. There is a problem, and the problem is quite chronic in nature. So always do a lymph node examination along with whenever we are doing the clinical examinations. Next, the maxillary sinusitis, just below the eyes, if you are pressing over the maxillary sinus area, there will be pain. So in the history I said about the maxillary sinusitis, yes, we should always do a clinical examination, and some patients give a complaint that they get pain when they are walking or running or they are jumping, and when they are simply sitting there. Again, whenever they are jumping, walking or playing or something, and if they give a complaint of pain, then it is most probably it is originating from the maxillary sinus. Okay, always remember that whenever there is a decayed tooth which is restored in, for example, a maxillary molar or second premolar, and if there is a maxillary sinusitis, the restored teeth will give a symptom of pain. Actually, it is an exaggeration of the maxillary sinus through the tooth. So even if there is a restoration and if you think that it is painful, do not jump to a root canal treatment or something. Always take a radiograph and do a proper examination. You might go for a course of an antibiotic, then we can re-examine before jumping into the final conclusion. And we always omit attrition. So in case of all old patients, there could be an attrition, and whenever we see attrition, we don't see it as a big problem, and maybe there is a generalized attrition, and what we said is, yeah, it's all attrited, there could be sensitivity. It's not only sensitivity. Sometimes there will be pulp exposure and there will be severe acute pain, or maybe there will be an extreme sensitivity. So just imagine this, you would have at least come across one of your patient in your clinical practice. Sometimes the patient gives some extreme means extreme sensitivity, the tooth will be non-vital. In case of some non-vital tooth, the patient will give, instead of pain, they will give some extreme sensitivity, especially whenever there is some attrition. So attrition patients and giving extreme sensitivity, and we can think about that there could be a problem of the tooth could be a non-vital tooth. Okay, so let's stop the presentation here, and in the second part I will continue. This is going to be quite a long one. So in the second part we will continue with the vitality testing, and we will continue with the radiographic examination. Otherwise it will be too long. So have a nice day, and next week I will come up with the second part of diagnosis in endodontics, and it will be going to another session which will be enlightening for your clinical practice. Thanks for watching till the end. Have a nice day.